We have three speakers where they will share their research and insight on this field of maternal and child health and well-being, from developing a tool for allocating nutrition interventions to looking at the linkage between women empowerment and vaccination coverage of children, and as well as group antenatal care and its effect on using the prenatal services. So each talk will be about 22 minutes, followed by 5 to 6 minutes Q&A. With that being said, I would like to introduce our very first speaker, Sylvia Lutz from Institute for Health Metrics and Evaluation, IHME, at the University of Washington. Sylvia is a member of Simulation Studies. And today, Sylvia is going to share her talk on introducing the Sonic tool for optimal allocation of antenatal and young child nutrition interventions with microsimulations. Please.
Hi, everyone. Thanks, Navide. It's so exciting to be here. As mentioned, my name is Sylvia. I am with the Simulation Science team at IHME. So we're going to be talking about a nutrition optimization project today. Before I get going into the meat of the presentation, I did want to include a note about some of the language we're going to be using. Our team really wants to acknowledge that not everyone that gets pregnant and gives birth is a cisgendered woman. And so rather than using words like maternal, as the name of this talk is, we're going to be trying to use some more gender inclusive language. So in places where you might be used to seeing the word maternal, we're going to be using things like pregnancy related or sometimes antenatal. And in places where you might be used to seeing the word women, like pregnant women or women of reproductive age, we'll be using pregnant and lactating people or women and birthing people. And I'd be happy to share more about why we feel this is important if you're curious. So to get started with some introduction, as I'm sure will be surprising to nobody in this room, pregnancy-related and neonatal disorders are a huge source of DALYs in the world today. And are incredibly important to ensuring the health of all people. However, clinical trials, while they're very important, can remain costly and tend to be highly localized in nature, which is why it's helpful to have things like simulations or other models, as many people in this room I'm sure do, to take those results and generate new outcomes and findings. So to that end, we will be looking at specifically nutrition interventions for pregnant people, healthy children, and children who are malnourished, and trying to understand some of the interactions and benefits and trade-offs across this prevention and treatment continuum. In particular, given a single fiscal envelope, so constrained cost scenario, what is the optimal product collection that has the most impact on pregnancy-related and child health outcomes? So we're looking at a few different interventions here. The first, we have a set of antenatal supplementations. These are things like IFA, MMS, and BEP. BEP is macronutrients for people who have low BMI pregnancies. And then we also have some child nutrition interventions. This top one here, SQLNS, this is designed as a preventative treatment given to all people to prevent malnutrition before it starts. And these other bottom two are treatments for malnutrition. So we have treatment for moderate acute malnutrition and then treatment for severe acute malnutrition. And the moderate acute malnutrition, we did break down into a targeted, which is designed to just reach some of the higher risk cases, and a universal MAM treatment. So these really span between kind of the pregnancy, small child, prevention, and then treatment. And just to show a few high-level results before we get into the methods and everything else, for increasing budget size, we found that first you would scale up a lot of these antenatal interventions such as MMS and BEP, then you'd move into SAM and SQLNS, and then lastly MAM. So just to kind of explain this graph on here, this is the coverage of the intervention, and this is the annual budget. So you can see at very small budget sizes, you'd start by scaling up MMS, Then this is overtaken by BEP plus MMS. So this is a combination. It includes both of the products. Then as you start increasing the budgets a little bit more, you scale up this SAM and SQLNS together, and then MAM kind of comes last at the end. So this is a broad picture of, depending on how much money you had, what would be the ideal thing to do in each scenario. To kind of get a little bit more into the methods, I wanted to start with doing an overview of what microsimulation is and what that means when we say that word. So the idea of a microsimulation is you have a broad population of people, and at a high level, this population of people matches to the global burden of disease study. I work for IHME, so we use global burden of disease data. And the idea is that it's a big math model where each individual person at a whole matches these population values, but on an individual level, they have a unique set of heterogeneous markers, and these markers and health statuses then determine their life course. So things like what disease they might experience, what treatment they might be able to receive, and ultimately any morbidity or mortality that they might accrue over time. Because we have this flexible microsimulation model, it also allows us to include different interactions in the model. So for example, if a birthing person received different supplements during pregnancy, later their child might have different values for birth weight, gestational age, or even stillborn versus not stillborn status. Now that we've covered a little bit about why a microsimulation, to get into what our actual model does, we have over here those antenatal interventions that I mentioned earlier. So the top two are micronutrient supplementations, and this BEP is again for low BMI pregnancies. And these values can affect a few different things. First, they affect the pregnancy outcomes. So antenatal anemia, this maternal disorders or pregnancy-related disorders, and then ultimately morbidity and mortality related to pregnancy. However, these also have an impact on the newborn outcomes. So things like infant birth weight, gestational age, and whether the child is stillborn. And so we take all of this data from our pregnancy simulation and we put it into the child simulation. And so this continues that pathway forward where you can see some of these outcomes that we saw, like birth weight, feeds into the child growth failure model. There's also other things that feed into the child growth failure model. For example, the child interventions. So treatment for acute malnutrition or prevention feed into how many children are wasted or stunted. This is all related to each other. And ultimately, the child growth failure model feeds into risk of infectious disease and morbidity and mortality. By using this model, we can track many outcomes, including deaths and DALYs, but also other outcomes such as child time alive, child time not stunted, or cases of wasting. So we take all of this data, and that half of it feeds into the top half of these optimization metrics. So that gives us the health data that goes into that optimization equation. And so, as I mentioned, there are many different optimization metrics. Today for my presentation, I will be showing things optimized to DALYs, but we do have data across many different metrics. And then the other half of any optimization equation for financial is the costs. So what do things cost and how do we attribute that? A high-level overview of our costing. We do assume a linear cost coverage curve. That means that at every single point in the coverage, it costs the same amount to add one additional unit of treatment or prevention. To generate our cost values here, we did a literature search. We use different kind of ingredients in the costing. One of those is product costs, one of those is distribution costs. There's also service costs and other programmatic costs. And so how we conducted this is we did a large literature search and found different values for each of the products in each of these different categories to then sum them together and generate the costs that we actually use in the model. And so we'll be showing results for this default column today, which is kind of the either average of the different studies we found, or in some cases, the ones that we felt was the most appropriate or relevant based on the effect values that we were using. And we do also have high and low sensitivity values. These represent some of the more extreme higher low options we found in the literature search. And while we won't be sharing a ton of sensitivity results today due to time, it is important to note that we have a lot of these options in different costing numbers. The last thing in the methods, before I kind of get into some of the results and how we analyze these, is how we generate baseline costing. So one of our big results is we're trying to understand if you took the same baseline budget and you distributed it in the optimized way according to our model, what would happen? It's important to note that our baseline budget value is not a value that we got out of thin air. Instead, what we're doing is we're taking these cost numbers that I've shown on the prior slide, and we're combining them with coverage estimates of these different interventions to come up with a baseline budget number. So as you can see, we're assuming that today there's IFA usage, there is SAM treatment, and there's MAM treatment existing. And so these are used to generate that kind of baseline budget estimate. I do also just want to note on this slide, we do have a concept in our model of CMAM screenings. This is community management of acute malnutrition. What it is, it's basically that cost of having somebody go to the different locations and screen people for MAM or for SAM or for SQLNS, distribute the SQLNS. This is basically that like service cost for all of the child nutrition. It's the cost of having somebody travel and provide screenings. I do want to note also that this CMAM screening is shared between any of the child's nutrition. So there is kind of this synergistic value in our model where if you have multiple child nutrition products in play, the CMAM screening cost ends up being shared between them. And so you can see that the highest value of any child nutrition matches the CMAM screening values. And so that's why that is. So some results when we ran this model. We are showing results for Ethiopia today, mainly due to time restrictions. We also do have results for Pakistan and Nigeria, but we're going to talk about Ethiopia. So here, this is around that baseline value that I was talking about. We have the baseline coverage estimates. This is that IFA, SAM, and MAM that we were seeing on the previous slide. And if you changed and did this based on our model in the optimal fashion, rather than investing here, you would invest in MMS and BEP, and then in SAM and SQLNS next. Showing this a different way, this is the same type of results, but this is now looking at the costing. So previously we looked at coverage, this is looking at the cost. So again, it's the same products. We can see that in the baseline, you're spending quite a lot of money on these CMAM screenings, and this value goes down as it's now split between SAM and SQLNS. The total amount of funding into the antenatal interventions also increases a decent amount here from that IFA moving into the MMS and then BEP plus MMS in the later optimization. And then lastly, if you completed this and magically reallocated everything overnight, how many more DALYs could you avert? The answer is quite a lot, 580,000 DALYs, or approximately 6,500 deaths annually in Ethiopia, which is a very significant number. Now, if you had more money and you could continue to expand past the baseline, what should you do next? So we can see here the graph that I showed earlier, where again, we have this MMS and then BEP plus MMS, and then you start scaling up the SQLNS and the SAM. This dotted line is that baseline value. So you can remember from earlier how we saw these four products being in the first optimizations. If you continue to have more money, you would finish your scale up of SAM and SQLNS, and then you would eventually scale up MAM in your higher budget ranges. Showing this in terms of costing, this is, again, showing very similar information, but this is now what you spent the money on. So again, you can see that you start with MMS and then add in BEP and then scale up some of these other treatments. This is kind of being able to visualize how that money is translating into dollars over time. One of the interesting things that I want to highlight on this slide is if you look at this red here, it actually starts to go down and decrease in the higher budgets levels. That's because as you're including more of the MAM and SQLNS treatment, you actually have to spend less money on SAM. So this is where we can start to see some of those really interesting interactions where spending more money on moderate acute malnutrition would ultimately be able to decrease the amount of money you'd have to spend on severe acute malnutrition because there would be less children that needed that treatment. And then lastly, we have a slide showing the DALYs. So this is kind of that DALYs over time. So you can see again our budget. As you might imagine, there's a pretty significant increase in DALYs averted that then starts to plateau over time as you're moving into some of these less cost-effective interventions. There's lots of additional results that we've done as part of this project. As I mentioned, we have multiple additional countries, including Pakistan and Nigeria. At a high level, a lot of the results and like the banner headlines are pretty similar across these countries. However, there is always in-country nuance between them. Additionally, there's many sensitivity analyses, including different metrics. How does this look different if you optimize for deaths, child time alive, child time not stunted, wasting cases, etc. You can change the cost values. As I showed you, we have other sensitivity values or to other numbers. We also, and I think this is important to highlight, we do count stillbirths in our model as deaths. So if there are fewer stillborn children, we do count those as deaths averted. This is somewhat controversial in the world of global health, and so we do have the option to include or not include stillbirths. And you can change the population of interest. If you only wanted to count or look at young child mortality instead of pregnancy-related mortality, there is an option to do that. Which kind of brings me to our Sonic tool. As I was mentioning on the prior slide, there's lots of different sensitivity analyses and a lot of different things to explore in these results. They're very rich and very nuanced, and different people might have different contexts or settings or cost values that they might want to use. And so because of that, we are in the process of creating the Sonic tool, or the Simulating Optimal Nutrition Intervention Coverage tool, which we've abbreviated to Sonic. So the idea here is that we've put a lot of these results into a Shiny tool that we are hoping to make publicly available very shortly. So individuals can experiment and play with these different what-if scenarios and start to understand and explore the results. So if you wouldn't mind switching to the website, thank you. Yeah, and you're going to have to reload it. So this is our Shiny tool. This is kind of a prototyped version that includes some of our early results. We are working to expand it and make it publicly available. As you can see, we have a bunch of different optimization parameters. So we're just going to run kind of the baseline to show you what this is able to do. But in theory, different people can be able to go and change to different countries, different optimization metrics, population, stillbirths, and then below this is all of the costing inputs. And so the idea is that individuals can say, you know, I want to understand what would happen if the antenatal interventions are very expensive or the child interventions are very cheap. And then as I kind of shared results both for baseline and then for a full scale up, if you had infinite dollars, we also have both of those options available on the Shiny. So hopefully the results will appear any second. Perfect. So this is the same type of information I was showing. You can see here how we have IFA, SAM and MAM, and how we reallocate it to MMS, BEP, SQLNS, and SAM. As we saw in the presentation, you can continue to scroll down. And a lot of these different coverage and other graphs that I was showing. But this will regenerate for different countries or different contexts, depending on what you're interested to explore. I didn't include the ICERs, but we do have ICER data. And then this is the DALYs. These numbers are slightly different because the Shiny tool has different costs currently inputted. But if you changed all of them to the costs that I used in the presentation, you would get the same outcomes. Thanks. Can we flip back to the PowerPoint? Awesome. So that's the Sonic tool as it exists today. As I mentioned, we're hoping to have it be publicly available. We're also hoping to expand this in a couple different ways in the coming months. The current version of the tool has preset values for everything. We're hoping to work with some folks to create more nuanced and different results, such as having costs that are outside of our preset options that we've provided, or having some more interesting nuanced things. For example, if in your country you know that having IFA at 50% is not going to change, and what would you want to do after that? Those types of more nuanced, interesting questions, we're hoping to be able to have more customization in the tool. So if you're interested in that, please come talk to me or let me know. And then lastly, we're adding a targeted SQLNS intervention, which should be in the next version of all of these results. That's all I have for the presentation today. Thank you so much for listening, and I'd love to take questions.
Thank you so much. Yeah, we have plenty of time for questions.
Yeah, thank you for the interesting presentation. I just want to know what informed the choice of those three countries, Ethiopia, Nigeria, and Pakistan. Is there anything common, or is there anything they have in common?
Yeah, that's a great question. I think these were driven by some funder motivations. However, I do think that these three countries are indicative of a lot of the global health emphasis in the world today, and they do have some interesting both similarities and differences. For example, on the baseline coverage slide, which is going to take me a second to get back to, there are some pretty significant differences in some of these baseline coverages. For example, Pakistan has pretty high rates of antenatal care, but pretty low rates of SAM and MAM treatment. There's also some interesting nuances in what outcomes might be interesting to different countries, where some places are much more focused on, for example, stunting and eliminating stunting, whereas others might be more concerned about wasting or child mortality. So I do think these represent an interesting range of different locations that have maybe different unique challenges and different unique baseline values. But I think this would be really interesting to do in additional locations or countries.
Sure.
Yeah, thank you for the talk. This is really interesting and great to see. Could you talk about how you incorporate uncertainty into your models and if there's a way to visualize it?
Yeah, I would love to. Let's see if we can find some good slides in the appendix. So the biggest way we incorporate uncertainty into our model is by using draws. So draws are this GBD kind of thing we inherit from GBD, where there are many different parameter values. So for example, we might have a value that we use for the impact of SAM treatment on wasting, or for the mortality rate of wasting, or the incident rate of malaria. And rather than just run this once with some mean value, we actually ran this model many times with different values. So each of those different runs represent a version of the world that could be real and could exist. And so by comparing across these different draws, what we're able to do is understand a bit about if these parameters were different, if the world looked a little bit different than this average version that I presented, how would things vary? So the high level, and we don't have to go a lot into this because I think it's somewhat confusing, is that we see all of the draws have the antenatal products, MMS, and BEP are prioritized first. And that makes us very confident in sharing those results and feel that even with this kind of parameter uncertainty, we're reasonably sure that this is a really great place to start. However, for those next steps between the child products, I was sharing that SQLNS and SAM is the optimized approach, and it is on average, but there's a lot of different variations. So in 40% of draws, we see SAM plus SQLNS. That's what I shared today. However, in 35% of draws, we saw SAM plus SQLNS plus targeted MAM all scaled up together. And so this is kind of that uncertainty that we did manage to include in the model. And we hope to share with other folks that there is a reasonable chance that this would be the optimal approach to include SAM and SQLNS and targeted MAM, or SAM treatment alone. We have some things that we're pretty confident in. SAM is basically always included in the next step of prioritization. But there's other things that uncertainty really does have an impact on. And we want to capture that uncertainty and share it.
Thank you. Fantastic talk. Just a quick question. So you've shown us how, given a certain amount of budgets, like what the optimal allocations of interventions should be. And I'm wondering whether you have to kind of flip it and say, given these available interventions, what should be the optimal budget be? Because sometimes, like on the program side, we often don't really think about budget until we know what we're going to do. So I'm just thinking about what your comments on that.
Yeah, I think that's a really great question. And, we do, per what you're saying, kind of have these results where we say, oh, just scale up SAM and SQLNS as much as you can, but you're going to randomly stop at kind of whatever this is, 40% coverage. That probably isn't what's going to happen in real life. That's pretty unrealistic. I think that this can be a great tool to start to understand those questions of what are the really good products that we should be prioritizing? How much does each product being scaled up cost? And then you can kind of work backwards to understand, okay, what are our priorities as a country? What metrics do we really want to work on? What products do we want to prioritize? And then what budget makes the most sense? We currently, in our version of the tool, don't have that kind of capability to do work backwards. It's something I would love to see us add to kind of say, what do you want to do and what budget would facilitate that? But that would be a really great ad for the future.
Much we have to move on to the next talk. Thank you so much, Sylvie.
Thank you.